Hello and welcome to the EduTalk series hosted by Biotone EduPartner School Program, and massage industry experts. With the growing interest and popularity of the EduTalk series, Biotone continues to support virtual learning and building massage community by connecting you with industry experts who share their knowledge and expertise on topics not only for class discussion, but career success. Today's expert is Whitney Lowe, who for over 3 decades has cultivated exceptional massage therapists worldwide with his dynamic orthopedic medical massage training. His career includes research, teaching, clinical work, and publications. He specializes in treating pain and injuries, pioneering the orthopedic massage approach. His training is recognized for engaging, accessible design, and comprehensive curriculum. Students both in person and online praise his approachable style and personalized training. Let's listen and learn as Whitney shares how knowing kinesiology and biomechanics helps to develop effective treatment plans that address underlying causes of injury and dysfunction. Recognizing the mechanical factors that led to or influence the physical dysfunction allows therapists to alleviate perpetuating factors and facilitate successful outcomes. Understanding the biomechanics of treatment options helps identify appropriate treatment techniques to promote healing and prevent further injury. Again, thank you for joining us. Again, feel free to chat questions or comments during the presentation to be answered in real time or at the end of the presentation. And with that, welcome, Whitney. Thank you so much for joining us with EduTalks. And I am going to turn it over to you and see you on the other side.
Okay, that sounds great. Donnell, thank you so much for this invitation. I want to thank also all the folks at Biotone for inviting me to be a part of the EduTalk series. I'm very happy to be here. And also to note that I have been a loyal fan and user of Biotone products for over 30 years. So started using Biotone way back in 1987. I remember that when I got exposed to it in massage school. So I've been a loyal fan of Biotone ever since then. So thank you all for taking some time out to join us here this afternoon. We're going to focus on some key things about biomechanics and clinical applications of that whole concept. And I want to try to dispel some myths and also sharpen your understanding of what biomechanics is all about and why I think it is so relevant for being a part of your practice when you're treating pain and injury problems. So I'm going to share my screen here and then we'll jump over and get talking about this here. All right, and it looks like everybody should be able to be seeing my screen now. Just let me know if you're not able to see that in there. So, so again, our talk today, we're going to focus on applied biomechanics for pain and injury problems. And what I want to do first is to kind of talk a little bit about the context of where biomechanics sits and why is it relevant for massage therapists. So one of the things that we're going to be focusing on here first is looking at, what biomechanics is and where it sits in this realm of the bigger picture of kinesiology, which a lot of us studied kinesiology in massage school and we're accustomed to the idea of, a lot of times kinesiology got kind of a bad rap, in my opinion. It oftentimes began to, be focused on just as a way to learn, muscle origins, insertions, and actions and things like that. And really, there's so much more to kinesiology than that. And that's what I wanted to get everybody to look at today, and also get an appreciation for all the different facets of it and why I think it is so valuable and so relevant. So let's look at what kinesiology actually is. It's composed of these 3 different sub-disciplines: anatomy, physiology, and then biomechanics, which we're going to focus on a good bit more today. So we're going to look at each of these three elements here and then talk about their clinical applications and how they're relevant to the things that we're doing in the treatment room. So first off, musculoskeletal anatomy. This is basically gets down to learning about structure, where things are, what's happening in different places, and becoming familiar with them. So that when, for example, a person comes in and says, "Oh man, I hurt my shoulder, I did something to it, can you help me with this?" One of the very first things that we do is to start thinking about, well, what's in there? What might they have done to it? What might they have injured in that process? So we've got to, bring our attention back to, well, what did we learn in massage school about those things that are located under the skin that are in this area? So this is all becoming familiar with anatomy. And I know a lot of people spent a lot of time learning anatomy simply to be able to pass their MLEX test or to be able to, get through their course, not thinking that this was going to be that relevant later on, or maybe forgetting a lot of it because you don't think about it a lot. But when you get to dealing with pain and injury problems, this is really important. So we need to have a very good grounding and a good understanding of what's under the skin, what's down there, what's in these areas, because when we start looking at how it's going to be impacted during various types of injury situations or things like that, we've got to know what we're dealing with. So that's why the musculoskeletal anatomy is a crucial part of this whole three-ring or three-footed stool of kinesiology. The second piece, neuromuscular physiology. So this one is crucial for looking at how does movement occur in the body? What are the neurological principles engaged with physiology that help us make movement happen? And there are some really important key principles about physiology that we might look at. So for example, you might have studied this a little bit in your initial learning of muscle actions when you were in massage school, but a lot of people kind of forget about it and don't pay much attention to it. But for example, when you're learning physiology, just with muscle contractions as an example, there's three main types of muscle contractions. The concentric contraction, where a muscle shortens, the two ends are brought closer together. As this top example here, is you're bringing the barbell up in an elbow flexion movement. An isometric contraction, where you're holding something, just holding it out in space and not allowing either a lengthening or a shortening movement, but there is still a muscle contraction stimulus to that muscle to engage. We engage in isometric contractions all day long just to hold us upright, for example. So all of the, stabilizing support muscles of the spine that hold us in an upright position are all engaged in isometric contractions constantly. And it's really important for us to be able to identify when those types of contractions are occurring, because they often play a big role in what type of injuries might have occurred to these different tissues. Because, for example, our third type down here, the eccentric contraction, these are contractions that involve a stimulus to that muscle tendon unit, but it's actually increasing in length. So this would happen, for example, when you slowly lower that weight back down to the ground. That is an eccentric action. And it's really important to be able to note when a concentric action is occurring or when an eccentric action is occurring, what type of muscle engagement is happening, because certain types of muscle engagements are more prone to injury. For example, more of your muscle strains occur from eccentric overload than from concentric overload. The unfortunate thing about this is when we're learning muscles and when learning things in school, when we're studying anatomy, all of our anatomy books focus on concentric contractions. So for example, in our picture example here, you've got the biceps brachii muscle engaged in a movement. If you look up the biceps brachii in an anatomy book, you will hear it say that the main function of that muscle is elbow flexion, which is the concentric action. But just as important is the role of the biceps brachii in doing an eccentric contraction. And so that's going to be an action where you're moving your elbow into extension, but that's still going to be an action of the biceps brachii muscle. So here, it's really important for us to recognize different types of muscle actions when they're occurring and where they might be contributing to different types of injury complaints. Now, when we look at the sort of the clinical applications of that, one of the examples I like to think about is what we call the neurofascial system, which is an immensely complex system of neurological sensors embedded throughout all of our connective tissues that give us tremendous amounts of information and feedback about what's happening in the body. So one of the examples that I like to use about this and why this is so important is you take the things that we do on a daily basis with massage. When you're doing a nice, soothing, and relaxing massage to your client, you are stimulating the nervous system in all kinds of ways. And it's all these sensory receptors throughout the connective tissues and in the skin that are responding to the level of touch and what we're doing. And then they may reorganize their levels of resting tonus in certain muscles or things like that. So if you've got a client that comes in and they're constantly tight and hypertonic in an area, they get a wonderful massage from you. They get up and they leave and they feel great. And there's increased movement and a sense of freedom and ease of movement now that they didn't have before. That has reorganized the neurological sensations from their nervous system back into the brain. And what we want to try to do, of course, is to make that last as long as possible. And there's a lot of things with what we do with massage that can really enhance that process to make it happen. So those are the first two, musculoskeletal anatomy and neuromuscular physiology, and some of the different application principles about that. Now, our third leg of the stool is biomechanics. And this is one of the more misunderstood categories. And that's why I want to kind of take the majority of our time today focusing on this in terms of getting a good understanding of what biomechanics actually is and how this relates to what we do in our practice. So in essence, biomechanics is the application of the principles of mechanical physics to the body or to an organism. So, I mean, there's biomechanics on the microcellular level as much as there are for us, but we're going to be focusing on the application of those principles of mechanical physics in relation to what happens with the human body during various different types of activities. So let's take a look at what that might involve. You're familiar with some of the biomechanical principles like inertia. You remember hearing about this probably even in elementary school, where it's stated that an object at rest will tend to stay at rest until it's acted upon by an outside force, or an object in motion will tend to stay in motion unless it is acted upon by an outside force. So whiplash is an example, a perfect example of this idea of inertia. So in our situation here, let's say you're sitting in your car, which is the common example of how whiplash injury occurs. This is the middle picture, the person sitting, whoops, let me back up just a second. This middle picture here, the person sitting with their head upright in a car. Then all of a sudden, they are hit from behind. And as they are hit from behind, their body, which is firmly attached to the car by way of the seat belt and gravity on the seat, gets thrust forward, but their head, which is not necessarily attached firmly with the seatbelt, stays in its position and it gets thrust backward rapidly. And then as soon as you stop with, by being pushed into the car in front of you, there's a sudden stopping of that inertia and momentum, and your head gets then thrown forward. So you've got a back and forth rapid whipping movement in the whiplash, which is the result of inertia. And we have all kinds of examples of inertia injuries that may occur, like when somebody is, falling down, for example. There's the body weight and the momentum of their body weight coming down to land, and the soft tissues have to absorb that force. That's a high level of momentum and an inertia that is getting absorbed or basically having to be absorbed by the soft tissues. And we can look at well, where are those tissues, and are they really capable of withstanding that kind of load, or are they going to get overwhelmed by that kind of load? These are some of the things that might make a big determination on how severe or significant an injury condition was. The next concept from biomechanical or physics that we want to talk about in biomechanics is the idea of mass. This is a very important factor also in a lot of injury conditions when we talk about what kind of mass was involved in the forces that were applied. So you have here an example of two objects, one a softball and one a shot put. And I don't know if you've ever picked up a shot put before, but that sucker is heavy, okay? So I don't know honestly what a shot put probably weighs. I'm going to guess somewhere in the neighborhood of maybe 20 pounds or something like that. Somebody can probably correct me on that. Let me know how much a shot put weighs. So I'm gonna say 17 to 20 pounds, something like that. Anyway, softball, obviously much lighter. So the amount of matter contained within an object is much greater in the shot put than it is in the softball. And this has a lot to do with an impact trauma. For example, if you are hit by a flying softball or hit by a flying shot put, there's going to be a very significant difference in how that mass impacts the tissues of your body. Likewise, if you are an individual with large mass, if you're doing a sporting activity and you are doing, let's say, a contact sporting activity like football with a huge football player that weighs 230 pounds and they're coming at you with a high velocity, that's going to be a much harder impact on your soft tissues than it is if you happen to accidentally get crashed into by a 5'2" gymnast, let's say, for example. So the mass or the amount of substance within that object plays a big role in what kind of forces are going to be involved in various types of trauma that the body might be subjected to. Now, this also comes into play as we talk about some other things with how we're applying forces during massage techniques too, and I'll get to that here in just a moment as well. We'll look at that after we look at this concept of force. So force is the amount of effort required to either accelerate or decelerate a mass. We just talked about mass a moment ago, and it requires a force to move that mass. Now, these two that are at the top, compression and tension forces, are the main ones that we're going to focus on with soft tissue injuries. There are 5 different types of forces that you might encounter in the body, but 2 of them are responsible for probably, 85, 90% of the soft tissue injuries that we see. And those are compression forces and tension forces. So again, just to kind of define each one of these, compression forces are a force where 2 structures are pressed closer together. So an example of this would be like a nerve compression problem where something's squeezing a nerve in the carpal tunnel. You're putting compressive force on that nerve and causing damage to the nerve fibers. Tension forces are when something's getting pulled excessively. A good example of this is the muscle strain injury or a ligament sprain, where there's an excessive pulling or tensile force on those structures that pulls them apart and causes the damage to those individual tissues. So that's a tension injury. The over on the left-hand side down below here, torsion injuries involves something where there's a twisting or rotation. Now, we don't have many torsion injuries of soft tissues because it's really hard to twist a soft tissue to the point of causing damage or injury to it. You'd have to really, really twist a soft tissue to make that happen. And we just generally don't have soft tissues that are that pliable that you can apply enough torsion force to them to cause an injury. Now, sometimes we'll talk about torsion forces applied to it, let's say to a joint, for example, because you can, in fact, twist a joint and rotate that joint to the point that you cause damage. But what you're doing inside the joint is not necessarily twisting those ligaments, but you're pulling on those ligaments with tension forces to the point that those ligaments would get injured. Down below, shear. This is a type of force where 2 structures are sliding past each other. So a shear force, an example of a shear force injury would be a condition like spondylolisthesis, which is a pathology where the lumbar spine, the 5th lumbar vertebra usually, slides forward on top of the sacrum and can, it happens as a result of stress fractures in the posterior aspect of the lumbar vertebra. So that sliding force can cause irritation to local soft tissues, as well as pulling on them and causing them to be a part of the injury as well. So that is a shear force injury. Now, bending injuries, we just really don't see those in the soft tissue world. You would see a bending injury, for example, in the world of orthopedics when you talk about fractures, because let's say in a sporting activity where you're skiing and you've got those ski boots that come halfway up your shin, and maybe you fall over forward and your shin is bending across the top of the boot. You're going to bend your tibia a slight bit before it actually will fracture and break. So that's a bending force applied to those tissues. You can kind of see why bending is not an issue for soft tissues because they're just so pliable. Bending doesn't really matter. So that's why we talk about those other 2, the top 2, compression and tension being the big ones that we're going to watch for. Now, here's another aspect of force application that I really want to call attention to, having to do with what we do in our massage work. So, for example, we talk about an amount of force that might be applied. And if I'm applying that force with my entire hand over the course of this area that I'm working, let's say the backside of this person's thigh, the force that I'm applying, and let's just say for the sake of math, that I'm applying 12 pounds of pressure. That 12 pounds of pressure is going to be spread out over my entire hand, which means there's going to be a lot less pressure in any one specific location. And this is why it's really good to start a lot of work in very painful areas with a broad contact surface first, because you dissipate the pressure level and you decrease it from being such an aggravating sensation of really irritating those tissues. But sometimes, a little bit later on, you're going to want to get a bit more specific with your work, and that's where we'll go to a small contact surface. So now if I apply that same 12 pounds of pressure through my arm, wrist, and hand, and directly through my thumb into this area here, that's going to be a much more concentrated aspect of pressure applied right in this area, and it's going to feel a lot more intense for my client than it would if I was using my whole palm to do that, because the broad contact surface spreads it out. The small contact surface that lets you get a lot more specific and a lot more localized, and then the pressure application is much more penetrating directly down underneath where you're applying that pressure with your thumb in this area right here. So pay attention to this with the different types of work that you're doing. It does give you a tremendous amount of variety in the various different strokes that you're using, because you can take any massage stroke that you currently use as you're working on people and think about, well, this is really usually done with a broad contact surface, like my forearm or my whole palm or the backside of my fist. What would it be like if I used a small contact surface, like a thumb or a fingertip or a knuckle or an elbow or a small pressure tool? What's that going to feel like when I work those muscles much more specifically? And when you do use those small contact surface applications, we generally want to be focusing a lot more specific attention on a particular area. So this is usually a bit more intense for the client, but a lot more specific in the type of work that we're going to be doing. So keep in mind, this provides a lot of variety for the different types of massage techniques and strokes and methods and things that you're doing with your techniques already. Now let's get into some of those concepts about how we apply these principles of biomechanics. And mainly I'm going to focus here on how we're applying some of these principles in the process of evaluating injuries, because this is a big factor where biomechanics plays a critically important role. So let's talk about how do we apply some of these principles and how do they take us to that place. The first thing to think about is that, why do we really want to go about doing this? Why is this clinically relevant? And the main thing is because the assessment process that you go through, which is that process of trying to identify what is the nature of an injury that my client has sustained, your assessment will drive your treatment decisions. So you can certainly have a client that comes in and says, like, oh man, I hurt my shoulder. Can you help me? And say, like, yeah, I know a bunch of shoulder techniques. Let's just start doing some things and see if anything helps. You can take kind of a shotgun approach like that, but I promise you that your treatments will be much more effective with your clients if you know and understand a little bit more about the anatomy and structure in the region, the physiology of what those different tissues do, and that you can apply some principles of mechanics to identify what might have happened in this particular injury and what tissues might have been involved in that injury to what degree that caused them to have injury sustained to them. And so that's what we're trying to do here with the assessment process, is focus on what is it that can tell us about the nature of these problems and how they've occurred, and how we can then make a good clinical intervention that's going to be very effective in addressing those problems with people. So what I want to look at here is 5 mechanical scenarios of what might happen to different tissues as we go through this process with them. So I'm going to take each one of these 5 scenarios, and then we'll look at what happens to different tissues under certain circumstances with different types of injuries as well. So the first thing is actively shortening. So we looked at this back when we were talking about neuromuscular physiology. Certain tissues, and only basically muscles is the only one, that can actively shorten. Now, we can also say fascial tissue has the capability to actively shorten to some degree, but not in a way that it can really significantly impact movement with mechanical force. It's not going to move your bones significantly. So our main focus with active shortening is going to be on muscle tissue, because that's the tissue that, when it gets a contraction stimulus, pulls its two ends closer together to move the bones. Okay, so we got active shortening. We also have active lengthening. This is also going to happen with muscles being engaged with the lengthening process, like during an eccentric contraction. So during active lengthening, when a muscle is in an elongation phase during an eccentric action, it is increasing in its length, even though it is still getting a contraction stimulus. So that's our second scenario. Then we have the other possibility of passive movements. So during passive movements, you could have tissues that are passively shortening, meaning they're just getting, their two ends are being brought closer together, but there's no muscle activity involved. And you should recognize this as the main different types of basic range of motion evaluations that we do: active range of motion testing, passive motion testing, and then manual resistive tests, which we'll get to here in just a moment. But during a passive shortening, there's no muscle activity engaged, but the two ends of these various tissues are brought closer together and they will slacken. Then there is a passive lengthening option. Greatest example of that would be stretching. So anytime you're doing a stretching movement with your client, you're engaging a passive lengthening process, because they're not, and again, this is assuming you're not doing some type of active or facilitated stretching method that involves muscular contraction. If you're just doing passive stretching, you are bringing the two ends of all of numerous tissues farther apart and putting tensile stress on numerous tissues as they are passively lengthened. This could be muscles, tendons, ligaments, nerve tissue, fascial tissue. Numerous tissues could be passively lengthened if you are moving a limb into a certain position, for example. And again, this is why our anatomy is so important, to understand what's in this area and what are we actually affecting with these different forces that we are applying. The last one being an isometric or manual resistance. So if a muscle is engaged in a contraction, but there's no movement occurring during your evaluation process, this we saw earlier is noted as an isometric muscle contraction. And we often do this to see if there's pain increased with muscle engagement when there is no motion occurring at a joint. And that's really important, because that usually pinpoints some type of muscle involvement in the injury condition if there is pain associated with that isometric resistance, but there's no motion occurring at the joint. Okay, so we've got these 5 mechanical scenarios, and now what I want to do is I want to take the 5 of these things and we're going to apply them to various injury conditions and see what's happening during each of those different examples of injury conditions. So I've got a series of moderately complex charts here that I want to go through. And don't feel like you need to try to remember and see everything that's on these charts, because at the very end of the presentation, I'm going to tell you where you can get a copy of these charts and download them for free and go back and reference them. I think they're very handy and very helpful in the assessment process here. So first one that we're going to look at here is for muscle tissue. Now, what we've got here on the left-hand side are the most common types of injury to muscle tissue. So we have muscle strains, where the two ends of a muscle are pulled apart and there is either an overstretching or tearing of that muscle. We have muscular hypertonicity, which is just basically tightness in muscles, and myofascial trigger points, those tight sort of areas of small areas of hyperspasm within muscle tissue. And again, this middle category here, it's kind of interesting. You know, you rarely will hear somebody going to a physician and getting diagnosed with muscular hypertonicity, but isn't that also the main reason that most people come to see you, is pain in muscles that are simply hypertonic or tight? So as simple as it sounds, it's probably the bread and butter of what most of us spend the vast majority of our time working on. And then thirdly, down here, a contusion, which is an impact trauma to a muscle. And again, this could vary significantly, like we talked earlier about force levels and force loads, based on the amount of force or mass in something that hit a muscle. that contusion will be, you know, mild or could be very severe in a lot of circumstances. Now, so here's how you use this chart. Let's go back up to the top here to this first one to look at muscle strains. We said if a person has sustained a muscle strain, when that muscle is actively shortened, would that be painful? So when you're doing your range of motion testing, for example, if a person actively moves this, and this is going to tell you here, it's generally painful if the load is sufficient. So a lot of times, let's say if there's a muscle strain injury and you do an active shortening action there, if there's a significant load on that, like you try to lift something up on a damaged or a strained bicep muscle, it's probably going to hurt. But in certain circumstances, that might not be painful. If, for example, there's not enough load on the muscle tendon unit. So let's use the example of the person who maybe sustained a strain to their elbow extensors from an excessive epicondylitis episode or something like that, or maybe a sudden onset injury to the wrist extensor group. If they simply do an active motion of moving their wrist, they're generally not going to have enough load on those muscles to cause that to be painful. And so consequently, during your range of motion evaluation, you might say, well, hey, this is active movement and we're using those muscles, but it's not painful, so there's nothing wrong with those muscles. But that's not necessarily true. The issue is if you don't put enough load on them during that active shortening, that might not show up. So again, we'll look at each one of these. So with muscle strains, we'll look at what happens during active lengthening. Is there likely to be pain when you're actively lengthening that muscle? Is there likely to be pain with passive shortening of it, passive lengthening of it, and manual resistance? And then we'll look at that for each one of these different common types of muscle pathologies. So we refer to this on our website as the assessment cheat sheet. And I have found it a really helpful way to just quickly get an idea of what might be going on. And does this pattern that your client is demonstrating, is that pattern indicative of a particular type of injury problem? Now, remember, none of this process is done in a vacuum. It's going to be done after you have already gone through a comprehensive history. You've taken a lot of information from your client. You've found out how did this come on? Is it sudden onset? Is it gradual? What kind of things led to that being a problem? Those are going to be all critical factors that will help you determine, again, what might be going on as you look at each one of these different types of injury conditions. Okay, so that's muscle tissue. Now we can do the same thing as we look at a number of other tissues. Here, for example, is tendon tissue. And you can look at our two examples of here, tendinosis, which is the chronic overuse that tendons are susceptible to, or another problem that's common with overuse problem with tendons called tenosynovitis, where there is an inflammation or development of adhesions between tendons and their surrounding synovial sheath. We see tenosynovitis occurring most commonly in the distal extremities because those are the tendons that have those synovial sheaths. You don't have synovial sheaths around your tendons in most of the other parts of your body, like your rhomboids, your erector spinae muscles, your rotator cuff muscles, and your shoulder. All those don't have sheaths around them, so they're not exposed to tenosynovitis, but they would be susceptible to tendinosis. And this is the most common type of injury that we see occurring in chronic overuse tendon disorders or to tendon tissue overall. So again, we've done the same thing with this chart. We've looked at active shortening, active lengthening, passive shortening, passive lengthening, and manual resistance. And again, what you're looking for when you do these patterns of evaluation and you're doing these various range of motion tests with your client is you're looking for some type of pattern that would tend to make sense for a particular type of injury. So, I often say to folks in our classes, if you remember what is the essential rule of real estate, and that is location, location, location. So that's one of the places where you start and you say, well, what's located in this area where they're having pain? And you try to identify, is this pain likely to be from a local tissue insult, or is it maybe being referred to this area from somewhere else? And then if it seems like a local tissue insult, and maybe there's something in their history, either chronic overuse or a sudden onset injury condition that would indicate some type of mechanical overload on those tissues, that's when these things in this chart really come into play and make a great deal of help. Now, I will be honest with you and tell you the one place where these charts and looking at the biomechanics is not particularly helpful is in many of your clients who have chronic pain syndromes like fibromyalgia, the pain that comes along with chronic fatigue, or chronic nociplastic nerve disorders, where there's sort of a disorder in the nervous system which causes extreme hypersensitivity to pain. We're looking in those situations at something other than mechanical forces causing further irritation of the pain sensation receptors in the body. So that's something where these particular methods aren't going to be as effective. But again, you'll want to pick that up as much as possible in your history before you've even gotten to that point. So we've got tendon tissue. We can do the same thing with nerve tissue and look at what happens. The mechanical types of injuries to nerve tissue usually involve either compressing that nerve or putting tension on it by pulling it excessively. You don't hear a lot about nerve tension injuries, but they're just as important as nerve compression problems, because a nerve can get overstretched and overpulled and cause a lot of the very same symptoms that we see with nerve compression problems. So again, we'll look at it during all these same 5 different variations of active shortening, lengthening, passive lengthening, and manual resistance as well. We can also look at joint capsules. Joint capsules are an important one that massage therapists tend not to focus a great deal of attention on, because we kind of maybe forgot about them much since we learned about them in anatomy class in our entry-level training. But joint capsules are richly innervated, and they can definitely be playing a major role in pain complaints, especially in certain joints, like in the shoulder. The joint capsule of the shoulder is very richly innervated, and it plays a very important role in the mechanics of shoulder. So when you have something like adhesive capsulitis or frozen shoulder conditions, the joint capsule is often implicated in those problems, and we want to pay attention to what's happening to that joint capsule under these different types of scenarios when we go through and do this in evaluation. Okay, now these next several tissues here are slightly different because they also span or are located close to the joints, but there's not enough length in these particular tissues to make them overly stretch or elongate the way a lot of those other tissues will. So these tissues are much closer to the joint, and they'll be affected by movements, but not to the same degree. So we see, for example, we just refer to them generally as active movements, passive movements, or manual resistance, because they can't really significantly slacken or lengthen the way those other tissues would. So this is going to be true of ligaments, and the most common injury that you see with ligaments is, of course, a ligament sprain. So, well, this is what would happen during a ligament sprain, during active movements, passive movements, or manual resistance. Same would be true of joint cartilage injuries. The most common cartilage injury that we think about most is osteoarthritis, for example, but there can be other types of cartilage injuries as well, like osteochondritis, but they're all going to have very similar types of results during the active movements, passive movements, and the manual resistance as well. So again, these are all tissues located very close to the joint that don't have that same capability for extensibility that those other tissues have. And then bursa, which are the small fluid-filled sacs surrounding various or located near various joints that are helping to reduce compressive forces between adjacent structures. And the bursa are often compressed by other things that press on them during these different movements. So again, knowing something about the anatomy and mechanics of bursa and how they get impacted in some of these different areas is going to help you focus a great deal of attention on what is going on with them. So these are some of our major soft tissues that we're going to be working on here for the evaluation process. And as I mentioned, you can pick up a copy of our assessment cheat sheet off of our website. This is our website at the top of the page up here, the Academy of Clinical Massage.com. And I really encourage you to grab a copy of that cheat sheet, and it will help you start thinking along these lines of biomechanics, of what happens during various types of injury conditions, what happens during some of the ways in which you're applying forces to the body. And I'd encourage you to think about that a little bit as you're working too, as you're doing some massage techniques next time you're in the clinic room. Think about the forces that you're applying with broad contact surface versus small contact surface. And is that, producing, more directed force down into those tissues that can more effectively sort of accent a specific tissue deep down below which you're working, or are you doing a more broad contact surface application that's got a lot of really good neurological responses and a great kind of soothing aspect to it as well. So again, these are some of the basic concepts about kinesiology and biomechanics in particular that I think are crucially important for us as massage therapists, especially if you're going to be dealing with pain and injury conditions. So again, I invite you to hop on over there, and you'll also find information over there on how to contact me. You're certainly welcome to send me if you've got any further questions or anything like that. I'm always happy to answer questions from you. Again, I wanted to thank Biotone so much for giving me the opportunity to talk with everybody here today. And I'll click stop share on this and entertain any questions or anything that anybody has.
That's great, Whitney. Thank you so much. Very informative. I wanted to go back to the whiplash part. When someone comes in for whiplash and you're assessing, you're still using these same assessment tools or categories.
Yeah, absolutely. Because what we want to think about with whiplash injuries are what are all the different tissues that might have been injured. So for example, you got to think, that's when we go back to anatomy. You got to think, well, there's all those little joint capsules in the cervical facet joints. There's these supporting ligaments that span between adjacent cervical vertebrae that could have been sprained or injured. There's muscle tissue in there that could have been injured. There's possibly even, nerve tissues that could have been overstretched or overpulled. And so we look at signs and symptoms to try to give us an indication of which of those different tissues might have been injured. And this becomes really important because this is also going to set the ground for the clinical decisions that we make about should we work on this person or should we refer them out to somebody else, or do both. Can we work with them but also maybe refer them to somebody else if we think they might need further evaluation as well. But again, these things wrap up all together the anatomy, the physiology, and the biomechanical principles in there as we make determinations about what we're going to do for effective treatments.
All right. And along the same lines, I don't know, I'll call it computer head, where, everyone is kind of curled over, your head is down or whatever. The same process for, oh, my neck is killing me. The same assessment process.
Yeah, but that's a good point that you bring up, because this is when we talk about biomechanics, you have to think along different lines here, because a whiplash is a sudden high velocity, high force load to those tissues. What you're describing, what people oftentimes now refer to as text neck, which I hate that term,
Okay.
but that forward head posture from long periods of looking down at things. That's a long period of isometric contraction on muscles, but we're not putting an overwhelming force on those soft tissues. So you don't have the same kind of thing, like, for example, you're not going to get a ligament sprain from working on your computer. Okay. You're going to get a ligament sprain from a whiplash injury in an automobile accident, but you are going to get chronic muscle hypertonicity from long periods of isometric muscle contraction from your head being held in poor posture all day long working on your computer screen. So this is why, looking at the elements of the mechanics and the history is so crucial, because it's the history that's going to tell us a lot about what is the scenario and the situations under which this has occurred.
All right. A chat came in. Thank you for the presentation. Would you speak for a moment about judicious uses of thumbs to treat the client effectively and to preserve the thumbs throughout your career, not blowing out the thumbs?
That is a great question, because lots of folks have tended to do that. And I will say the way I was taught to do massage was doing it with a lot of thumb work, and it can absolutely wreck your thumbs over the long haul. So there's a couple of important things to think about here. So we talked about the broad contact surface applications, which are great for soothing techniques and broad-based applications. But I also like to work really specifically on certain muscles and certain tissues because it gets great effects. But that can cause you to overuse and overwork your thumbs over the long haul. So my caution to you is a couple things. Number one, conditioning. That means condition your thumbs for the activities that you're doing. I have just got this thing on my desk right here. I cannot remember what this thing is called, but it's a little rubber ring. And it's, I'll try to see if I can remember the name of it, but like I just keep it on my desk and I work it, all, when I'm just sort of sitting there reading things. This is exercise conditioning and strengthening for your fingers and thumbs to condition them for the load that you're going to be putting on them. But, more importantly too, you don't want to overuse them in any situation. So I've migrated to doing a lot of work with pressure tools instead of using my thumbs or other small contact surface. Sometimes I'll use a knuckle or fingertips or an elbow or someplace, but there's a lot of places like the lamina groove of the spine where you can't get your elbow in there effectively. And I'm not crazy about, trying to do some high pressure things with elbows in certain locations. So I've got a couple different pressure tools that I really like working with, but they all have very small tips on them. And what I'll do is I'll use the pressure tool in one hand and I'll put my other thumb right next to the pressure tool and let this thumb feel what the tissues are doing. So I can feel, I still have that responsiveness of feeling how the tissues are responding, but the one with the pressure tool that's the one that's applying the force in there. And I would encourage you to do some work with those. I wish I had a link right available here to you, but there's a tool. Actually, let me put this in the chat down here. There's a tool, you can look this up on the web, called the Shemala finger, Shemala. That is my favorite pressure tool. I love those things, and it's very inexpensive. It's like less than 20 bucks. You get a pair of them, one that's shaped like a thumb and one that's shaped like a finger. And they're really good because it's got a ball on one end and then the finger that protrudes from it. And that ball fits really nice in your hand. And then you just do your like long specific stripping techniques with that pressure tool. And then the other thumb is right next to it, feeling how the tissue is responding. And so I'm glad you brought that up because that is a crucial aspect of being able to do that type of really highly specific small contact surface pressure work, but also have a long career, because you definitely don't want to blow your hands out doing that.
Definitely not. Everyone, we have another few minutes for questions and comments to come in. And Whitney, while we're waiting for any further chats, where will you be out and about? And why don't you mention your podcast, The Thinking Practitioner?
Yeah, absolutely. So I've got a bi-weekly podcast. We've been doing it for about 4 years now with Till Luca. It's called The Thinking Practitioner. And our focus in that podcast is to have interviews with brilliant, influential minds in the world of massage and body work. And also Till and I sometimes just have conversations between the two of us about clinically relevant things. And we sort of pose questions and ask each other things. And we'll talk about research papers. We talk about various different conditions. We talk about sticky subjects that are hard to talk about for massage therapists, but impact your practice a lot. So I would encourage you, come on over and take a listen. It's called The Thinking Practitioner. You can find it on Apple Podcasts or Spotify or wherever you happen to listen to your podcast stuff. There's also you can get it through my YouTube channel, which is at Whitney Lowe. Just look that up on YouTube. We have our podcast in a video format as well. So we've got our podcast over there. And also I've got our ongoing online programs that you can find out information about over at our website at academyofclinicalmassage.com. This is where we really delve into this stuff in a whole lot more detail, putting together a comprehensive picture for helping people learn how to treat pain and injury problems, because there are so many people out there who need your help with various pain and injury problems, and massage therapists are in an ideal position to be able to do that. So I also do get around the country periodically to a few locations, heading out to Framingham, Massachusetts in just a couple weeks. And then a couple weeks after that, I'll be over in Lake Oswego near Portland. And I know we'll be down in Atlanta in the fall, and we got a few other sites that we're going to be putting together for the fall as well. They'll always be posted on our website. So if you hop on over to my website and grab a copy of that assessment cheat sheet, that'll also put you on our mailing list to keep up with all the things that we're doing. Get our weekly clinical research newsletter where we talk about all kinds of things happening in the clinical world, and also keep you updated on things that we're doing there as well. So.
All right. So,
oh, I love it. Somebody gave us the Olympic shot put weight, 16
yes.
pounds. I was pretty close, wasn't I? I think I said 17 to 20. So,
And will you be at AMTA National?
I don't know that I'm going to be at A&T National. That's Tampa this year, right?
Yes.
Right in your backyard, sort of, almost, kind of. Yeah, somewhat near there. So
Yeah.
I don't know if I'm going to be down there yet at that time, but I will try to get down there this year.
Okay.
Yeah.
And what was the name of the massage tool you mentioned?
It's called Shimala Finger, Shemala, Shimala Finger.
Okay.
Shimala Finger breast massager or something like that. Yeah.
All right. Well, I'd like to mention to our audience that watch your inbox for a follow-up email tomorrow. And if you don't see it by the end of the day, maybe check spam. We will have a copy of the recording. I'll include the Shimala finger tool, Shimala finger tool. Whitney's contact information will be in there as well. And so keep an eye out for that. Also, the upcoming Edu Talks, which are May 7th, we have Sheila Alexander. Prepare for the Silver Tsunami, Geriatric Massage and Spa Therapies. On May 14th, and for those of you that aren't aware, we have the EduTalk Diabetes Series to help you with your special need clients. We have Dr. Jonathan Spags, How to Successfully Reverse Type 2 Diabetes Without Fancy Diets, Starving Yourself, or Exhausting Exercises. And on May 21st, we have Pete Whitridge, Therapeutic Strategies for Surgeries, Scars, and Burns. Again, watch your inbox for invitations to upcoming Edu Talks and also for follow-up on Whitney's presentation tonight. And thank you all for joining us. I think that's it.
All right, that sounds good. And I'd like to say thank you again to Biotone for sponsoring this wonderful series of talks with such great presenters that you have going on here. And I thank you very much for allowing me to get to participate in it as well.
Well, great information shared, and I know it's just the tip of the iceberg. So thank you, Whitney, for all you do. And thank you, everyone, for all you do as well and for attending. Join us again.
Okay.
Where do we find charts again? You find charts on Whitney's website.
My typing is not so fast, but academyofclinicalmassage.com.
And I'll include that in tomorrow's follow-up email as well.
Yeah.
Thank you, everyone. Take care.
Okay, sounds great.
We'll see you again.
Thanks again.
Okay, bye-bye.